Hello, good day, everybody. My name is Baha El Zain. I am a second-year internal medicine resident at DMC Huron Valley Sinai Hospital. Hopefully, everybody can see my screen that I'm currently going to talk about. So, our QI project was based on it's called Modified CIWA protocol. So, so let me just start talking about the background a little bit. So the Clinical Institute Withdrawal Assessment Alcohol Revised, so the CIWA scale, it's used by physicians and healthcare practitioners, to assess various alcohol withdrawal clinical symptoms, to really examine and pay close attention to symptom triggers for benzodiazepine. It's a to keep patients from going into withdrawal, essentially. So it's a well-established, widely used scale. So overall, benzodiazepine is the main drug administered to treat the psychomotor agitation exhibited by all these patients for alcohol withdrawal symptoms. So, moving forward, that being said, we're going to talk about overall, comparing CIWA versus phenobarb, and what is, if it's possible to adjust or modify our CIWA scale at the hospital to see if there's something more superior. So something that we're going to compare it to is phenobarbital, which is a long-acting barbiturate. It has a half-life of actually 140 hours, which provides us, the physicians, an alternative compared to the conventional benzodiazepine, such as like lorazepam and, Ativan, as we all know. So, certain study, Nasivik reported that like phenobarb use did not show a statistically significant difference in primary outcomes related to complications like seizures, delirium tremens, ICU admissions, or secondary outcomes when compared to the standard care of benzodiazepine, despite a higher rate of prior withdrawal-related complications. So, despite these trials showing consistent efficacies and safety of phenobarbital in the management of alcohol withdrawal, benzo therapy still remains the custom alcohol withdrawal syndrome treatment. So objective for this study, our goal was to determine if a regimen of phenobarb and diazepam for the management of alcohol withdrawal syndrome leads to a fewer withdrawal-related complications when compared to our standard CIWA protocol. So what we did, all teaching services and ICU patients being managed from December 2021 to roughly February 2022 were included. Patients were either placed on phenobarb and diazepam, so phenobarb and Valium, or their standard CIWA protocol, which is lorazepam. And then our primary outcomes included length of stay, ICU length of stay, severity of alcohol withdrawal, like seizures and need for intubation, and so forth. So what the results came out were, out of the 30 patients that were used in this study, 12 were loaded with phenobarb in the emergency room and started on the diazepam, TID, and then 18 of the patients were on your standard CIWA protocol, so lorazepam, oral or IV. Of the 12 patients on the phenobarb, 2 of them went to be managed in the ICU with an average length of stay of 2.5 days and a total length of stay of 4 days. Both patients in the phenobarb diazepam group that required ICU management were essentially intubated, and the doses of the diazepam administered ranges from 2.5 to 10 milligram TID. So loading doses for those patients were, and in the 11 of 12 were 130 milligrams of phenobarb, with one patient receiving a loading dose of 260. The phenobarb loading dose were administered at the discretion of the emergency medicine attending physicians in the ED. Unfortunately, 2 patients originally placed on the phenobarb diazepam regimen were also given lorazepam for the breakthrough tremors and agitation, just so what they felt comfortable with at the time, the physicians. And 18 patients who received the Ativan, the lorazepam, your original CIWA scale, 10 of which were oral and 8 of them were IV. Of the total 18 who were placed on the CIWA, 8 patients of the 18 were essentially transferred to the ICU. Among them, 5 were intubated, and ICU length of stay was 4.5 days. So, just in conclude, I know we only have a roughly 6 minutes here. In conclusion, it remains unclear whether a regimen of phenobarb and diazepam is superior to our CIWA lorazepam treatment in the management of alcohol withdrawal syndrome. Initially, impression appears though patients who receive the lorazepam, Ativan, based on the scoring are more likely to require ICU admission and a prolonged length of stay. However, An explanation for this finding may be that physicians are just more comfortable reverting back to the tried and tested standard of care for alcohol withdrawal, CIWA, that we're so used to, particularly in the more ill patients who are more likely to require more intensive levels of care. Another conclusion is that physicians are more reluctant to schedule benzodiazepines. So in this study in Assates, he demonstrated that symptom-triggered approach to therapy individualizes treatment and decreases both treatment duration and the amount of benzodiazepines used. Despite the CIWA treatment arm having comparatively prolonged length of stay, symptom-triggered benzodiazepine use is associated with a decrease in both treatment duration and quantity of medication. So although phenobarb is an older agent that's fallen out of favor, it is seeing a rise in clinical use recently, possibly due to established superiority among patients at greater risk of experiencing dangerous complications should they withdraw. So overall, in conclusion, although it remains unclear if phenobarb front-loading with scheduled diazepam reduced the risk of alcohol-related complications when compared to CIWA, the study does highlight the safety and efficacy of phenobarbital along with the need for further research. Future studies concerning this topic should assess the risk of recurrent withdrawn patients receiving phenobarb compared to standard lorazepam, as well as the outcomes amongst patients with previous history of withdrawal seizures. Again, thank you so much for your time. And this is our QI project. I want to thank Erica St. Lawrence, Jeffrey Lee, Joseph Owens, and David Alderi, my co-residents in this. Again, my name is Baha El Zain. Thank you so much.